Hello everyone, Dr. Med Ed. Today we'll talk about infective endocarditis. It is the Dukes criteria that we use to diagnose endocarditis, and is a mnemonic called B-timer. B-E are for the major, and timer are for the minor. The major criteria are blood culture positive ×2 that are 12 hours apart, or endocardiographic evidence of endocardial involvement, and that can be done on TEE or TTE. There are 5 minor criteria: T for temperature, for fevers, I for immunological phenomenon, so these include Oster nodes, rough spots, glomerulonephritis, or positive rheumatoid factor. M stands for microbiological evidence not meeting major criterion, meaning a blood culture that's like one set that's positive, or a blood culture that has a bacteria that is not common for endocarditis. E for embolic phenomenon, including septic, arterial, pulmonary emboli, myocardic aneurysms, intracranial hemorrhage, or Janeway lesions, and conjunctival hemorrhage, etc. R for risk factors, if the patient has a predisposing heart condition, which we'll talk about later, or IV drug use. Now, for a definitive diagnosis of endocarditis, the patient will have to meet 2 major criteria, or 1 major and 3 minor, or 5 minor. For possible diagnosis of endocarditis, the patient would meet 1 major and 1 minor, or 3 minor criteria. Here are some detailed explanation for some of the criteria. For positive blood culture, it is by common endocarditis organisms, or 1 blood culture positive, or serology positive for Coxiella, and also or persistently positive by common organisms despite appropriate antibiotics. For echocardiogram, there will be vegetations or valvular abscess, new prosthetic dehiscence, or new regurgitation, and those will meet criteria for echocardiogram. For minor, for predisposing cardiac condition, and these would include high risk patients or medium risk, and high risk include prior endocarditis, rheumatic valvular disease, aortic valve disease, including bicuspid or complex cyanotic lesions, prosthesis. For complex cyanotic lesions include congenital heart diseases, and medium risk involving mitral valve disease, including mitral valve prolapse, mitral valve regurg or leaflet thickening, and also hypertrophic cardiomyopathy. And these are some patients with abnormal risks of bacteremia, such as increased risk similar to IV drug use, and these also, and others include indwelling venous catheters, poor dentition, if they're on hemodialysis, has a history of diabetes, or has intracardiac devices such as pacemaker or ICD. And this slide indicates the common endocarditis bacterial organisms. So you see these 5 groups. They will meet the major criterion, given that they're positive in 2 bottles that are greater than 12 hours apart. And these include the streptococci virulence group, Streptococcus bovis, Staph aureus, the Hayseck group, including Haemophilus, Aggregatibacter, Cardiobacterium, Legionella, and Klebsiella, and lastly, Enterococci. Now we will switch gears a little and talk about the algorithm for TEE or TTE. So if a patient has suspected infective endocarditis, we group them into low risk or high risk. And low risk patients include unexplained fever, chronic murmur that has not changed, no stigmata of endocarditis, such as those immunological lesions or septic lesions that we mentioned in the Duke's criteria, no high-risk anatomy or prosthesis or device. The patient is high risk if there is a significant new murmur, there's new heart failure, patient has prosthetic valves, has leads or devices, has signs of endocarditis on exam, prior endocarditis history, high-risk anatomy, including congenital heart disease, and if the bacteria in the blood is positive for Staph aureus. If the patient is low risk, we start with a TTE, and if the imagers are limited or there are high-risk findings, which we'll talk about later, then indication for TEE. But if the patient is high risk off the bat, then it's recommended we can start with a TEE. And if there's any question about LVEF function or the hemodynamics, we can pursue a TTE, but usually that's not needed. These are the high risk findings on TTE that we mentioned before. So these include large mobile vegetations. If there's any question of perivalvular extension of the infection, if there's a grade 3 to 4 regurgitation, so severe, or if there's new LV dysfunction. Let's say you got the TTE and it's negative, then if you have low suspicion, then you have to consider other diagnosis. Or you still have high suspicion, then you will pursue a TEE. If it's positive, you treat it. If it's negative, then you will consider other diagnosis. If the initial TTE is positive, there are no high-risk TTE findings that we mentioned on the previous slide, then no TEE is indicated unless there's a clinical decline. So you would just treat. But if there's high-risk TTE findings, you ask for a TEE and then you treat. Here, if you got an initial TEE positive, you treat. If it's negative and low suspicion, think about other diagnosis. If it's negative and still persistent high suspicion, you can repeat a TEE in 5 to 7 days. If it's still negative, consider our other diagnosis. Positive, you would treat. Here are some indications for surgery. These include severe valvular dysfunction with congestive heart failure and an emergent indication if there's refractory cardiogenic shock, uncontrolled infection, if there's periannular abscess, worsening conduction, increase in vegetation size, or persistent sepsis. Persistent sepsis means positive blood culture after 5 days of appropriate antibiotics, IV, or there's recurrent systematic embolization. If the patient has prosthetic valves, especially with valve dysfunction or dehiscence, there's Staph aureus or gram-negative rods infection of the prosthetic valves, and also surgery for Staph aureus, fungal or multi-resistant organisms as well. If you thought this video was helpful, please like, subscribe, and look out for my next video. Thank you for listening.